So what I hope to share today is to sort of tell the story and bring life to this data through my lens as a clinician researcher, and maybe help us think about some of the potential implications for this in the work that we're all doing in clinical practice and also in research. So thank you for having me today. I'm going to be talking about country differences in substance use among HIV-positive Latinos in the U.S.-Mexico border region. And I'd like to acknowledge my co-authors from SDSU School of Social Work, Dr. Reed, and also my mentor, Dr. Zuniga, who generously shared this very rich data with me. I will give just a little bit of background about HIV prevalence in the region. I think this has been nicely covered by several other colleagues here today. But California is the state in the U.S. with the second highest HIV prevalence. And in San Diego, we have the third largest number of HIV cases in California after San Francisco and Los Angeles. So there's over 13,000 people living with HIV in San Diego, and what's specific about our region is that 42% of these cases are among Latinos. In Mexico, and Dr. Strathy alluded to this earlier, we may not have all the data available, but what is available is that Baja California, where Tijuana is, ranks 8th in 31 states in AIDS cases, and there's 8,000 cumulative cases between 1983 and what's currently available in 2006. And the main takeaway from this is that we know from lots of research that Latinos are the group that are most at risk for having later HIV testing, entry into care, and are also the most vulnerable for falling out of care. So I'm going to talk today about some of the risk environments that are specific to HIV-positive individuals who use drugs within this region. And I'll focus on two in particular, the use of poppers and heroin. So poppers are alkyl nitrate inhalants. They are commonly used among gay men, and especially in relation to sexual encounters. And they're legally available for purchase in both the United States and in Mexico. And as you can see from these screen grabs, they're very heavily marketed to the gay community. And come with a lot of HIV-related risks. There's a lot of literature on this. I'd be happy to share some of the references later if people are interested. But that use of poppers is very associated with risky sexual practice. And in one study in particular, among HIV-positive MSM, popper use was correlated with serodiscordant, unprotected anal sex. So when we think about the risk environment of individuals who are positive in the region and who are using drugs, poppers play a big role in that. This figure shows the routes of heroin, and on this map we're only seeing the United States, but as you can see there's a lot of heroin available within the border region, especially here in San Diego and Tijuana. What you can't see are the routes as the heroin moves up through Mexico. And so a lot available certainly on the U.S. border, but even more important is as heroin moves up to be distributed into the United States and other places, there's a pool of heroin on the Mexico side of the border that's not able to cross immediately. And so there's a surplus of heroin available in these regions. And so this creates these risk environments in Tijuana and San Diego. So I'm going to be talking today about data from a project called Proyecto Acceso, which was a binational study of care practices and barriers to care among HIV-positive Latinos. So this is the secondary analysis I did on a cross-sectional study where convenient sampling was used to recruit 200 individuals. These were recruited half from HIV clinics and social service agencies in San Diego and San Ysidro, and half in Tijuana. The inclusion criteria are that individuals were HIV positive, okay, and identified as Latino, They were adults 18 years of age or older, and they resided in Tijuana or San Diego for at least 1 month within the prior year. They spoke Spanish or English, and they were able to provide informed consent. And these were interviewer-assisted HIV care outcome surveys that looked at various different pieces of HIV care. So lifetime and recent substance use, entry into HIV care from diagnosis until entry into care, and antiretroviral adherence. This study did have binational IRB approval through UCSD and also through Tijuana General Hospital. The data was collected in 2011 and 2012, and it was funded by the National Institute of Mental Health and also what is now the National Institute of Complementary and Integrative Medicine. So for this analysis, we wanted to use the risk environment framework from Rhodes, which Dr. Strathedy very nicely gave an overview of in her address this morning, to look at the prevalence and correlates of lifetime substance use among people living with HIV in the Tijuana, San Diego region, and really to better understand substance use risk environments, including the differences in availability and consumption on both sides of the border. And then hopefully start to think about some targeted interventions that can reduce harm and improve care engagement in this very vulnerable population. So in this sample, there were very high rates reported of lifetime substance use, and generally no difference in that between individuals recruited in Tijuana and individuals recruited in San Diego or San Ysidro. Almost 70% in both samples had reported some lifetime substance use. The most frequently used substances were crack cocaine and methamphetamine. I'm going to be focusing on poppers and heroin because these had significant differences for individuals recruited in Tijuana and those recruited in San Diego, and also because, as I've showed, these two substances in particular are associated with HIV risk. So I think there's a lot of literature about this around heroin and especially around injection drug use, but maybe less so for other substances that may pose risk to HIV through sex, not through their route of injection. Route of use. So we selected several predisposing factors for bivariate analysis, and these were theory-driven, how we selected these particular factors. Surprisingly to me, there was no significant correlation between age and use of poppers or heroin. And so we see some similarities in what was significant between popper use and heroin use, but also some differences. So for popper use, you can see here, was significantly associated with having been diagnosed with HIV for more than 5 years, overwhelmingly associated with being gay or bisexual, and then also with having health insurance in the United States. And I'm going to come back to this concept in just a moment. With heroin use, we see significant associations for individuals who did not identify as being gay or bisexual, and also opposite to poppers with having health insurance exclusively in Mexico. And interestingly, we also see that heroin use was significantly, can you guys see that? I can't see my clicker, but there we go. Significantly associated with actually entering into care, HIV care from diagnosis within 90 days. So to continue this, now when we look at popper use by primary residents, we see popper use is now associated with primary residents in Mexico. So we didn't have specifically a question that asked where people use drugs, but we had several different items that maybe were sort of a proxy for thinking about what a risk environment is. So with the first two indicators I mentioned, which was the site where they were recruited, which was a clinic where they were receiving care, or where they identified as having health insurance, which we know means that they had access to services in that country, we see pauper use associated with the United States. However, when we look at where people reported their primary residence, we see the opposite. So I think this is really key when we think about what a risk environment looks like for a very mobile, dynamic population who are existing in distinct and different risk environments, but that this risk environment is very fluid. And this may be an indicator that these are individuals who are able to cross in between both countries. We also see, and this fits in line with that idea, that pauper use was significantly associated with individuals who are able to cross the border at least one round-trip crossing in the past 6 months versus those who did not cross at all. The opposite is such with heroin, where individuals who had no border crossings reported in the past 6 months were more likely to use heroin. Also, incarceration was significantly associated with heroin use, as well as never having been deported. So again, I think that this starts to give us a picture of individuals who are mobile, who may have crossed in and out of both countries, and individuals who are not able to do so. So when we modeled this using logistic regression, we selected the characteristics that had significant association, and actually the only thing that was significant was individuals who identified as being gay or bisexual were over 9 times more likely to endorse pauper use. The large confidence interval is because this is a relatively small sample size. If you recall, of the whole sample, 40 people reported using paupers. Health insurance in the U.S. and years since diagnosis were approaching significant, but were not significant in this model. And so what this helps us understand is these are individuals who are the very most at risk and who we can really focus our interventions with. So as I stated, paupers were almost exclusively reported among gay and bisexual participants. And so when we think of environmental factors that may relate to these two particular substances, with pauper use, we seem to be getting a picture that these are individuals who have a higher ease of binational mobility. They're able to cross back and forth over the border more frequently. Whereas with heroin use, it seems to point to individuals who are not mobile, who have a history of incarceration and have not been deported. So what this tells us is that country residents in Mexico may indicate that these are especially vulnerable individuals to both pauper use and heroin. And so we're still doing analysis on this sample to kind of get a better picture of what that risk environment might look like for individuals who use heroin. Some of the limitations of this study was that this was a cross-sectional study, and all the measures were based on self-report. Also, these are individuals who are recruited from clinic or social service agencies, so these are individuals who are accessing care at least at some point. Certainly, more vulnerable populations out there are the ones that are not being recruited from in-service facilities. And that the measures we used were based on lifetime use. We saw very low reporting of substance use within the past 3 months, which may speak to stigma and people's willingness to share that information within the clinical setting. So in conclusion, what I think many of us in this room know, that this is a very dynamic mobile population, and so that complicates things when we're thinking about what a risk environment could look like. But doing binational comparisons of risk environment and also availability of drugs can help inform future research on really targeting interventions to reduce harm and better engage individuals who are HIV positive and living in the border region. Clinically, care systems who are serving this population can screen for substance use associated with these risk environments, specifically for poppers. I know in our clinic we talk a lot about substance use and I think have a pretty open dialogue about that. However, I don't think we're talking specifically about popper use, even though I work with a lot of young gay men. And also, when possible, offering integrated care for substance use in HIV clinical settings, and if not, making those referrals and linkages to care. Future directions can focus on binational prospective studies that focus on patterns and actually location of where people are using, and hopefully increase binational care coordination between providers who are working on both sides. And I will finish with acknowledgments. There were many, many community agencies that were involved in order to do this research, and especially to the participants who were willing to share their stories with us.
Thank you so much, Nicole. I'm aware that we're running a little bit behind time and everyone is eager for lunch, so, but I do want to open up the floor for just a few quick questions, if there are any. Yes, just right here.
The last time people can hear me. Is this on? Can you speak a little bit about how orientation was collected, and if I think you showed that heroin use was associated with heterosexual orientation, but are people in Tijuana less likely to identify as bisexual or gay? So was it asked as how do you identify, or are your sexual partners men or women?
So let me see if this is on here somewhere. It's not. So this was largely a gay or bisexual population, and we ran into the problem that Dr. Strathy mentioned earlier, where actually on the survey were included gender identity. Being transgender was included in the sexual orientation question, which muddied the waters a little bit. And so what I included for analysis was only people who specifically had identified themselves as either being gay or bisexual. So it's possible that that number is even higher. I didn't include people who identified as trans because I feel that that's a gender identity and not a sexual orientation. But I think so yes, the people were asked how they self-identified. They were not asked if they have sex with male or female, although there was an opportunity to write in, and a couple of people did write that in.
Thank you. Davey?
Hi.
Hi.
So that was great. You need to talk to Antoine because and Sarah, we have some very interesting data on popper use in the HIV reservoir. But
Awesome.
My question is about heroin's quite addictive, and poppers really aren't addictive. And I was just wondering, I had two questions about this. One, did you collect information about receptive anal intercourse? Because that's really oftentimes where poppers are being used. And whether or not it's ever used in conjunction with other substances sort of to heighten the sexual experience. That makes sense.
It does make sense. And this was not a survey that I was involved in personally. There are sexual risk questions, though, on the survey that do ask about number of sexual partners and condom use. So future analysis would definitely be interesting to look at that in conjunction with individuals who reported popper use.
One of the other just follow-ups on that I was thinking about is that whenever we survey Latino men who have sex with men, they're very hesitant to say that they're a bottom. So, and oftentimes those are the ones who use the poppers. So I'm just wondering if there might be a bias in the study. So I try to see if I could.
That's a really good point, and I don't believe that receptive versus not was asked about on the survey.